In the last part of our presentation about space closure technique, we will talk about techniques for two upper premolars extraction. This patient, she presents, as you can see, with relevant crowding that makes a very regular smile line. But, as you can see from the quarter and also for the profile, she has a fairly regular profile. You can see the lateral calf looks pretty normal, with pretty normal values, and this is a occlusion in which she's got a normal overjet, high labial cadence, and a full distal molar relationship. This is the ideal candidate for two upper premolar extraction therapy, meaning that the patient is really a class 1 skeletal patient. The class 2 molar is only due to the fact that the upper canine are totally out of the arch, and the space has been taken by mesial drift of first, second premolar and molars. So basically, is a patient with a normal, absolutely normal skeletal relationship, but a molar class 2 relationship. Patients that are real class 2, skeletal class 2, in which the mandible is retrusive, they are not ideal candidate for two upper premolar extractions. Two upper premolar extractions are best made in patients that have got neutral or very moderate class 2 skeletal and crowding in the upper arch and therefore distal molar relationship. It is in a case like this more reasonable to extract and distalize, because distalization, we know that for every mean up to 3.5 mm is possible to achieve with bodily movement. The rest is a purely distal tip, which is a risk factor for relapse. So in a case like this, we proceed to extract, and you can see that after extraction, actually there is not even need for space closure. We can just proceed with the normal treatment with leveling, repositioning of the brackets, and come to a nice conclusion of the treatment in which the patient will still have totally unchanged facial features. Her profile is still the same before and after treatment, still very straight with a good definition of upper and lower lip actually, because the incisor has not been moved at all. This is the final occlusal result. And the way to obtain a proper occlusal result, I will tell you there are a couple of rules for that. This is the final lateral teleradiography and final panoramic image. This is the comparison of the lateral radiography before and after treatment. You can see that the anterior part is totally unchanged. So these are patients which you can extract two upper premolars without having any kind of consequences on the profile. When we want to have two upper premolars and achieve a distal molar relationship result, we have to observe a couple of rules. Number one, in order to increase the arch length in the upper, and in order to have a proper occlusion in which the mesiolingual cusp of the upper first molar occludes in the embrasure between lower second premolar and lower first molar, we need to mesio-rotate the upper molars. In order to do this in a predictable and reproducible way, the best way is to use 0 degrees offset molar tubes for the upper premolar. So it's a very good idea to have in your inventory this kind of tubes. Number two, extract anytime possible the upper second premolars instead of the first premolars. This because the second premolar are statistically smaller than the first premolar, and therefore you will tend to maintain a good arch length if you extract those instead of the first premolars. You have to match arch length, because the only problem with this kind of treatment is that despite ending in distal molar relationship, you will tend to have an arch length discrepancy, with the lower arch being too long respect to the upper arch. So you have to apply all kind of possible orthodontic tricks to increase the arch length in the upper and decrease the arch length in the lower. You have to remember that it's indicated when there is crowding in the upper but not in the lower, so patients basically they are class 2 molar for a dental reason, not a skeletal reason. Can be indicated if there is an increased overjet that is due to proclined upper incisor, because it's the same principle. Patients that have got a skeletal class 1 or very mild skeletal class 2, they may have a very increased overjet due to dysplastic proclination of the upper incisor, and which then they are followed by mesial drift of the posterior dentition. So basically this patient, they will have a distal molar relationship, but a skeletal situation that is not so severe. In this patient as well, you can extract two upper premolars, since you will retrocline the upper incisor and end up in distal molar therapeutica result. It is not indicated in true class 2, in which you've got an increased overjet that is due to a true skeletal discrepancy. Because in this case, what you would do by extracting two upper premolars, you would just end up by chasing the lower arch and retroclining the upper incisor and ending up in a situation that is not acceptable cosmetically and functionally.